Our next speaker is Kim Lucas, who is the epidemiologist and research scientist with the California Correctional Health Care Services of the Public Health Branch. And her topic is valley fever among California state prison residents, epidemiology, prevention, and challenges. Kim, thank you.
Thank you very much. Thanks for having me this afternoon. There we go. So first, I'm just going to give you a brief introduction about the California state prison population and an overview, very high-level overview of valley fever epidemiology, and that would be among our incarcerated residents. And then I'm going to try to focus most of the talk on interventions that we have done and CDCR has done for prevention of infection and severe disease, with a focus on our medical restrictions and also the use of the Coxie skin test for stratification, and then wrap up with some successes, but also remaining challenges that are unique to our system. So the California Department of Corrections and Rehabilitation, CDCR, currently has approximately 97,000 adults in custody, and that includes around 95,000 in 34 state prisons and about 2,000 who are in 36 conservation camps or fire camps. Our population is 96% male, and our racial ethnic background is our most common group is Hispanic, just slightly overrepresented compared to the California community. Our Black residents at 28% compared to 7% in the community. And whites, of course, at 20% are more than doubly underrepresented in the prison system. This just shows on the map where we consider 10 prisons to be in the endemic area, in the yellow circle there. And then in the red circle, we have 2 prisons, Avenal State Prison and Pleasant Valley State Prison, which have always had very, very much higher rates than all of the other prisons, and in California. So in the last year that we had a peak in the state prison system was 2017, and in Avenal and Pleasant Valley we had approximately 4,000 per 100,000 case rate. In the other endemic area institutions, the other 8 of the 10, about 300 per 100,000, and that has always tracked very closely with the rate in Kern County, which always has the highest rate in California. Just some quick epidemiology, and more will come up later. In the top panel of the graph, you see Pleasant Valley and Avenal, and in the middle panel, the dotted line is Kern County, and the orange line is the endemic prisons outside of Avenal and Pleasant Valley, and the green line is the rest of the prisons. So through the kind of dips and peaks in California that were mentioned earlier, the rates in our state prisons follow roughly the same pattern. Pleasant Valley is usually about 3 times the rate of Avenal State Prison, and then you can see in the last few years, California is still, kind of continuing to increase, and we've seen in our non-endemic area prisons that there seems to be a slight increase overall in that area too. In terms of hospitalizations, our system has had electronic data since 2011, and the blue and orange lines just show the overall rate each year of total hospital admissions and individual patients who are hospitalized, and that has trended down despite another peak that we had in cases around 2016 and 2017. With respect to deaths, here shown from 2007 forward, we have had fewer deaths in recent years where cocci is the underlying cause. So we've had a wide variety of prevention interventions that CCHCS and CDCR have implemented since 2007, including our case surveillance system, environmental mitigation, air quality improvements, and then the restrictions from the 10 endemic area prisons, including medical restrictions, demographic restrictions, and risk stratification based on cocci skin test or immunity, are what I'm going to try to tell you about in the next 10 minutes. So 15 years of prevention. So this timeline starts in 2007. We implemented case surveillance, and also we implemented our first major medical restriction from all of the endemic area prisons in that yellow circle that I showed. And we call it cocci Area 1. That's where all of these restrictions apply. And so the way this came about is there was an outbreak at Pleasant Valley State Prison in 2005, and we requested assistance from the California Department of Public Health, and an investigation identified at least 166 cases, 29 hospitalizations, and 4 deaths among residents. And the rates were 38 times higher than the rate in the community, the city of Coalinga, and 600 times higher than the rate in Fresno County. And the investigation found that disease was associated with comorbid conditions, increased time outdoors, Black race, and older age. And so as a result of that, the first set of medical restrictions you see here were implemented. So immunocompromising conditions, severe COPD. There was also some planned expansion construction that was going to happen at Pleasant Valley, and that was canceled. We at CCHCS, Public Health and Quality Management, in the few years that kind of followed implementing those medical restrictions, we were looking at the data and ended up putting out a report. But basically we found that, despite those restrictions, the endemic area prisons didn't have a persistent decline. The rates were kind of moving. And 4 of the prisons, Pleasant Valley, Avenal, Wasco, and North Kern, all had cases higher than in their counties in 2006 through 2010. And then the rates at Pleasant Valley in particular were many times higher than their immediately surrounding communities in roughly the same time frame. So 6 times Coalinga State Hospital, which you see is right next door to Pleasant Valley State Prison, 17 times higher than in the city of Coalinga, and almost 500 times higher than in Fresno County. Also, roughly during this time period, there were 27 deaths with cocci as an underlying or a contributory cause, and the majority of them were in Black residents at a rate that was 8 times higher than the community in California. So back to our timeline here, kind of around this time while these analyses were going on, there were some environmental mitigations that were done at Pleasant Valley and Avenal, and then we were looking for what else can we do, particularly in Pleasant Valley and Avenal. And so this is where the next set of medical restrictions comes in. So we were asked in 2013 to look for additional factors that we might be able to use as restrictions from these 2 prisons. And so we did an analysis and found that during 2011, which was a peak year, that our Black residents were at 90% higher risk of primary disease and also disseminated disease. We also found that our residents with diabetes were at over 3 times the risk. And then also at higher risk, but to not as much of a degree, are Hispanic at 30%, and the older ages 40 to 60% higher. And so as a result of this, in 2013, the second set of medical and demographic restrictions were applied. And so all residents at Avenal and Pleasant Valley who were Black or Filipino or had diabetes were moved out of that area, and those groups are no longer able to be incarcerated there. So fast forward to 2016, we did some evaluation with our case surveillance data, realizing that we could compare 2 peak years. And so we looked at 2016 versus 2011, and observing that in California overall, 2016 was another record year. It was on par with 2011 in terms of rates, but had even more cases. So we looked at our cases at Avenal and Pleasant Valley, and instead of seeing another year like 2011, our 2016 had a rate that was decreased by more than half. And in the other endemic area institutions in outside of Avenal and Pleasant Valley, where the enhanced medical restrictions were not implemented, the rate remained the same. But overall in CDCR across the state, because of the large reduction in Avenal and Pleasant Valley, there was an impact to the overall rate in the system. Similarly to what I showed you before, comparing 2016 to 2011, we had a decrease in hospitalization rates and people hospitalized with cocci by more than half. This slide just shows the impact for African American residents whose rate decreased in 2016 by 80% compared with 2011. And because our rates overall had decreased, similarly other race ethnicities had slightly lower rates. And then in the graph you can see that, after these interventions, our Black residents had the highest rates consistently before, and since around 2015, 2016, they now have the lowest rates. Back to the timeline, our third major intervention that restricts people from being incarcerated at Pleasant Valley and Avenal. We consulted along with CDPH, with CDC, about what more could possibly be done. And in 2014, CDC predicted that we could get a 60% decrease in disease at Pleasant Valley and Avenal if we used a cocci skin test-based strategy where we could identify people who were previously infected and immune from being placed at Avenal and Pleasant Valley. In 2015, Spherusol became available. We did a statewide skin test screening offer in all of the state prisons. And then shortly after that, we integrated the skin test into the reception center intake health assessment screening. And the way the program worked out in practice and policy is that people with a negative skin test are restricted from going to Pleasant Valley and Avenal. So there's kind of a lot on this slide. I won't take time with the detail, but we looked at our skin test screening data and our case surveillance data, and we did some estimates of the performance of the skin test and concluded that if Pleasant Valley and Avenal were populated with residents only with positive skin tests, that we would actually be able to prevent 74% of cases. But currently, the population in those prisons, because people are allowed to decline, people who decline are still allowed to be there, about 10% are skin test positive. So we estimate that we're probably, in terms of impact, only reducing case rates by about 7%. And this is just to show that very similarly, as we move to a reception center screening model, the acceptance rates on average have been about 50%. It's kind of fluctuated, but similar to the population that's already there, ultimately we only expect about 8% of people who are moving into this area to be immune. So since this last major medical restriction, there has been some more just a couple. So we do have some challenges that are unique to our system. We do have a higher prevalence of risk factors for infection and severe disease among our incarcerated residents. And incarcerated people are moved around a lot. So we have a susceptible population, the majority of whom are entering prisons from urban and non-endemic areas. And then the medical restrictions apply to almost 1/3 of the prisons. And this has a really, a large impact potentially for people who are restricted to have access to visiting by family and friends if they happen to be, from that area. Programming, it's a challenge for custody operations. The low skin test acceptance has been a challenge to have additional impact throughout that. And as we heard this morning, we're really concerned about expanding endemic areas, which will end up overlapping with more prisons, and just the cycles with the droughts and peaks and how we respond to those in real time. In summary, we think that the mitigations and restrictions that we have done have appeared to decreased our rates and improved outcomes for our Black residents, but our rates still continue to be very high, much higher than the community. Thank you.
Thank you very much. Thank you, Kate.